Hello, everybody. Thank you for joining us for episode 3 of our series for the aging and the elderly. So, we've had a wonderful time with the previous 2 sessions, and I'm really looking forward to today's session, which deals with common ailments in the elderly. And I'm happy to say that our speaker for today is in the house. So, just a little bit of housekeeping. Everybody join in, kindly mute yourself unless you want to speak. Um, and please raise up your hand when it's time to ask questions. If you're not in a position where you're able to speak or your background is too noisy, please type your question in the chats. We'll be happy to have the chat as lively as possible when the meeting is going on, so feel free. And it's not too late to invite your friends and family to join us to be part of this session. My name is Temitope Aidun. Um, yes, thank you. Also known as the praising child. Okay, so we'll be starting the session right away. And I will just be giving a brief introduction of our speaker today. Just a minute. Yes. I'll be giving a brief introduction of our speaker today. And I don't know whether she would want a little break in between when I'll just talk about the Link family and she'll continue again. Is that okay? That's absolutely fine. Okay. Because I'm beginning to think it's going to be a bit of a long stretch because you're our main speaker for today. Okay. Yes. Yes. So we have, I'll just put her on the screen now. Now where she's disappeared now. Where she okay, found you. Yes. Okay. So we have Dr. Adebukon Tolulope Alalade, MBBS, MBBA. She's a clinical development physician and principal investigator with expertise in early phase clinical research, including first in human studies and clinical development strategy. She combines, uh, just 1 minute again.
Fatima, you're muted.
Oh dear, I've been talking to myself. Okay, I'll start again. We have Dr. Adebukola Tolulope Alalade, MBBS, MBA, who is a clinical development physician and principal investigator with expertise in early phase clinical research, including first in human studies and clinical development strategy. She combines a strong medical background with healthcare management expertise to support the development of innovative therapies through scientifically rigorous and patient-centered research. Dr. Alalade has led phase 1 and 2A clinical trials across therapeutic areas, including central nervous system disorders, pain, and rare diseases. As a principal investigator, she provides medical oversight for complex studies, ensuring participant safety, protocol integrity, regulatory compliance, and informs dose escalation and benefit risk decisions based on emerging clinical and safety data. Prior to clinical research, she gained broad NHS experience across geriatrics, GP, stroke medicine, pediatrics, obstetrics, and gynecology. Dr. Alalade holds an MBA in Healthcare Management from Anglia Ruskin University and an MBBS from the University of Ibadan, Nigeria. She is married with 2 children. Okay, join me as we welcome Dr. Tolulope Alalade. Yay, we are very
Thank
happy
you
to
so
have you in the
much.
house.
Thank you for having me. Hi, everyone.
Hello, over to you. The floor is yours.
Okay. I thought you wanted to talk about the Link family first, or did you want me to go first?
No, I wanted you to go first. I said you'll have a bit of a break in between, probably
Okay,
halfway. When you're ready to pause, just give me a thumbs up.
no problem. I'll do that.
Thank you.
I'm just going to share my screen. Okay, can we see my screen?
Yes, we can see your screen.
Okay, so hi, everyone. Thank you for the wonderful introduction. Temi is a wonderful colleague from University of Ibadan, so it's always nice to catch up. So today we're just going to be going through common ailments in the elderly, um, mostly about recognizing the signs, following the evidence, and protecting independence in the elderly as well. Why are we doing this? Why does this matter? So statistics show that 1 in 5 people in the UK are now age 65 or over. And by 2039, it's projected that that would be 1 in 4. About 70% of people over 65 to 74 are living with 2 or more long-term conditions presently. And then currently it's about 1 million people are projected to be living with dementia in the UK, but by 2040, it would most likely go up to 1.4 million. Hypertension and type 2 diabetes tend to appear earlier and are more aggressive in Black, African, and Caribbean communities, for which I'm sure are most of the audience for today. With the same resilience that has helped people build a life in the diaspora in Britain can make us sort of overlook symptoms and just basically say, I'm fine. And it's the hardest sentence to challenge when someone says that. So it's difficult to get people to talk about what's going on or for people to even bring that up in conversations because we usually have that lesson, whatever is happening, it's fine, all is well. And we just go on sort of ignoring the signs and the symptoms. It is pretty much a very hard task trying to try to talk about common ailments in the elderly because there's a lot of it. And even in medical school, that took weeks and months to be able to look into. And we have, less than an hour today. So I thought, what's the best way to do this? So for today, I'm just going to be sharing a few of the common ones. I would sort of talk about storylines using Nigerian British family life. And then we use one guideline, which is the NICE guidelines. And we'll do that about 8 times over, just look at the more common ailments in the elderly. So we'll be looking at hypertension, diabetes, heart failure, dementia, anxiety and depression, urinary incontinence, falls, and Parkinson's disease. So we'll take the first case study and we'll be looking at Mr. Babatunde Adeyemi, about a 74-year-old male who currently lives in Peckham with his wife. So he would occasionally complain about headaches and dizziness when he stands up. But as we mentioned in the beginning, he will insist he's fine, he's living a good life. He doesn't smoke, he doesn't drink, he still leads prayer most Sundays at church and during the fellowship as well. He denies any chest pain or shortness of breath. So from the symptoms we mentioned in this scenario, the most notable ones are mild headaches, dizziness on standing, fatigue, and blurred vision are the most common symptoms that would be noticed at home. Now, when it comes to hypertension, it's usually called a silent killer. Like in this scenario, people are basically like, I don't drink, I don't smoke, everything is just fine. Now, with hypertension, another reason why it's a silent killer is that most people do not have any symptoms at all. And so because they don't have any symptoms, they can't get treatment that is needed. So what usually will happen is that the pressure of the blood against the arteries, against the organs, against the heart will cause like significant damage. And these damages can most times be irreversible. And like I mentioned, people do not have any symptoms with this. By the time people get to notice, it's caused a lot of damage to the organs, and people will present with more significant presentations like a stroke or a heart attack or kidney failure. Now, when it comes to hypertension, there are what we call sort of, treatments that are non-medical, and that would usually be the first point of treatment. So we'll first confirm that it is indeed hypertension, and it will be defined as blood pressure greater than 140/90. And that would normally be done with a home blood pressure measurement or ambulatory blood pressure measurement. This because some people have usually increased anxiety when they're in the clinic scenario, or what we call a white coat hypertension. We can falsely raise the blood pressure. But once it's been done in this way, usually done at home, or they take a device home and do this blood pressure, and it's consistently high. There are different stages. So stage 1 will probably have, greater than 140/90. Stage 2, about, more than 160/100, and severe ones would be greater than 180/120 millimeters of mercury. Now, I mentioned that before we normally go into giving medications. So there are what we call lifestyle modifications. So one is usually the diet. So we will try and reduce salt intake in the diet, and then encourage things like, eating a lot of fruits and vegetables, and also reducing things like caffeine in the diet. When it comes to things like exercise as well. So in terms of exercise, having at least 20 to 30 minutes of exercise that would, cause a significant sort of like, increase in heartbeat or heart rate, at least once a day. And also for those that smoke, so sort of encouraging them to stop smoking. And then when it comes to alcohol, reducing the alcohol intake. So generally in the UK, one of the areas where we have, equality when it comes to, the sexes is that, the alcohol intake, the moderate should be 14 units for both male and female. So there's no discrimination there. And it's usually encouraged to have it, over 3 or 4 days in a week, and to have alcohol-free days. But if all that doesn't work, then we can move on to medications. So the guidelines we're using, NICE guidelines, recommend a calcium channel blocker as the first line for, again, Black African or Caribbean family, or people from Caribbean, as opposed to an ACE inhibitor, or to use the angiotensin 2 receptor blockers over an ACE inhibitor if one is needed. In terms of the target, it will normally depend on the age. So if the person is under 80, we would work with for targets with about 140, less than 140/90. And if the person is over 80 years, then we'll be looking into making it less than 150/90. Again, this will be adjusted for frailty and comorbidities. There are some times where we would need to urgently refer the person to the hospital. So, for example, if you have a home blood pressure monitoring device at home, and happen to take the blood pressure, and and you find it to be more than 180 over 120, the person is confused, they might have a chest pain, or signs of kidney injuries, like dehydration, we should urgently let them be seen in the hospital. So we'll move on to the next one, which is diabetes. So hypertension and diabetes are the most common ones. So again,
Excuse me. Yeah, someone just asked about just confirming that these are hypothetical names. And
oh
yeah,
yeah. So
yeah,
yeah, they
okay.
are hypothetical names.
Yes, I thought as
Yeah,
much, yeah.
yeah. So there's no data. This confidentiality is here. So the second again hypothetical case would be Mrs. Ngozi Eze, who's 69 but lives in Woolwich, and lives with her son. So if you have a person who's been increasingly tired and thirsty over the past month, and the son has noticed that she drinks water constantly through the night, and has been reducing her intake of pounded yam and her soup, in spite of that, she's still losing weight. And then sort of these common symptoms that we noticed would be excessive thirst and urination, fatigue, blood vision, slow healing cuts. So they have a cut and it's taking a long time to heal, or they have increased hunger. So again, when we look at this, so when one is, one thing they always ask is, we say, oh, they're having that portion, it's not because they're on a diet, it's because the body is asking for help. There's something going on. In terms of diabetes, again, there is no universal target. So what we call the HbA1c must be individualized, taking into things like the frailty and with the specific condition the person is in. So there is a standard target, which is 48 millimoles, and that's for most adults on lifestyle measures or people who are metformin alone. We'll have the relaxed targets for those who are frail or have people who have a lot more comorbidities. So 58 to 64 millimoles when there's hypoglycemic risk, frailty, or limited life expectancy. So the risk usually starts earlier at a lower weight, for those again with a background, Black African background, or from the Caribbean background. Again, just for us to remember that hypoglycemia in a fail older adults, it's not just a low blood sugar. It could mean an impending fall, an impending head injury, and we should not just take that as a low number. We should make sure that we get treatments as soon as possible. So we'll be going to the third one, which is heart failure. So this time we are talking about who is about 80 years old, and he lives with his daughter in Edmonton. So his complaint is that he's getting really breathless walking just short distances at home. So for example, walking from the living room to the kitchen, he gets quite breathless, and then he used to be able to stand for 2 hours without any problem, but that is now becoming a big issue. And then he's having to sleep using a lot more pillows because it's uncomfortable for him to lie flat. Again, the symptoms to be noticed here is breathlessness and exertion when he's walking. They can also have like swollen ankles, persistent cough, reduced exercise tolerance, and rapid weight gain from fluid. Again, when someone mentions, oh, they want more pillows, it's not, because it's just uncomfortable. They just want to be, a bit more comfortable. But really, it could be a clinical sign that something's pending and that needs to be looked into. In terms of treatment for heart failure, we normally measure what we call the BMP in anyone who suspects a heart failure before we do like imaging. So if the measurement comes back about 400 to like 2000, we should make sure that the person is seen within 6 weeks by a specialist and also have some urgent imaging done, which normally called the echo. But if the number is below 400, we should be considering a different diagnosis, and heart failure is unlikely. Again, diuretics relieve and not necessarily produce a cure. So when we have serum control, doesn't necessarily mean diagnosis. So the disease-modifying treatments is the 4 pillars. And when we mean the 4 pillars, so in terms of the medication that's usually used for heart failure, so these are beta blockers, ACE inhibitors, glucocorticoid receptor antagonist, and sodium glucose co-transporter 2 inhibitor. So that are the 4 major treatment that is used for heart failure. Again, in terms of statistics, so heart failure affects roughly 1 million people in the UK. So overlapping breathlessness, swelling, and fatigue usually will make it easy to miss. Moving on to our 4th case study, it would be dementia. So we can talk about Mama Owosu, who is 81. She lives alone and she has a son who would normally call her from Lagos and just to make sure she's okay. And now the son notices that even over the phone that she's repeatedly asking the same question. It could just be like, "How are you?" or how difficult, or just asking the same question over and over again. And then she's forgetting appointments. It could be, clinic appointments. It could be, going to church. People have just noticed that she's forgetting things a lot. And even more dangerously, it could be things like, leaving the cooker on after cooking, forgetting to put that off. And sometimes the family may just put that down to, oh, she's just getting old. So again, looking into this, there could be memory loss, confusion in terms of time or place. And with this, sometimes they could even like wander off and get lost. So they have difficulty with familiar tasks, misplacing items, poor judgment, personality or behavior change. So this is quite important to look to make sure that, serious things don't happen, like, they could accidentally just get the house burned down. So in terms of diagnosis, a good history is quite important. And it will also be quite useful to get history from someone who lives with them or someone who knows them quite well, just to be able to compare what they used to do and what they do at the moment. So there are a lot of cognitive testing that is done. There's a lot of neuroimaging that is done, not only to confirm the diagnosis, but the type as well, which would affect the treatment that will be done. So we would normally, again, non-drug treatments. So we have the ABC model, and basically the assistance, what caused it, what triggered it. Again, it would be quite useful to have, the history from someone who knows them, a collaborative history as well. So in terms of the behavior, what exactly happened? Did they get lost? Did they forget something? Did they forget to put on the cooker? And then consequences in terms of what happened afterwards. How did people respond? What type of support did they get? There could also be encouraging them to engage in physical activities. This would increase the blood flow to the brain and also reduce the cognitive decline. Again, brain healthy diet. So swapping, so sort of like white, rice or white bread to like brown bread or brown rice. Lots of fruits and vegetables, nuts for snacking. Again, fish, salmon, fish, oily fish are quite good and are quite, like we call them brain food as it is. Increasing the social interaction. So thankfully, also from the African, Caribbean society, we normally would have places of worship at the church, at the mosque, would normally come in quite handy in terms of social interaction, and then just sort of mental stimulation. So maybe it's like engaging them in discussions or making sure that they have puzzles around them. Also, sort of like surrounding them with pictures of family and when they were younger and things like that. It just helps to juggle that memory and keep things intact. Again, mentioning faith, um, a lot of things that the elderly will do will put it down, oh, it's normal aging, and then also, some spiritual courses and everything, but we should always look to make sure that rule out everything before we put it down to normal aging. And again, faith and clinical care should work together and shouldn't work, and in competition against each other. So we should always, keep our spiritual health, in good step, but always sort of seek medical help when it's needed, and we can use both of them collaboratively. So some would need medication. So we have cholinesterase inhibitors for Alzheimer's disease. There could also be mixed or Lewy body dementia, and then we use memantine in severe diseases. One major caution would be to make sure that they're not giving antipsychotics, because it can cause severe or dangerous sensitivity reactions in some particular types of dementia, like Lewy body or Parkinson's dementia. Moving on to our fifth case scenario, which would be anxiety and depression. So this time we would be using Folashade Adebayo, who's a 76-year-old who lives in Camberwell, has been widowed for the last 8 months. So her committee nurse notices that she rarely leaves the house and has stopped attending the women's fellowship meeting that she once loved. Now, friends keep telling her to be strong and to pray through. So again, common symptoms could be sort of like persistent sadness, poor sleep, loss of interest, poor appetite, excessive worry, restlessness, and social withdrawal. So again, not to confuse grief with depression. So grief would be more sort of transient, and they'll have like intervals where they sort of have a laugh and feel relieved, while depression will be more persistent and pervasive. So when Be Strong is the only thing on offer, it can quietly become something else. So let's always make sure that we look into it and make sure that we know what's happening. So again, comparing grief versus depression that we've mentioned. So in this scenario, this is someone who's just lost a partner. So we shouldn't just put it down to, oh, this person, is grieving. But we should make sure that it's not something deeper like depression that has set in. There is a start low intensity, so there could be stepped care, guided self-help, group cognitive behavioral therapy, social prescribing, which is just making sure someone goes over, has a chat with them, make sure that, okay, all this can be done before medication can be prescribed. We should always be comfortable with asking difficult questions so that we know what we're dealing with. So if it's an older adult, we're not quite sure, is this person just grieving or did you have depression? Let's feel comfortable with asking, have you felt down, depressed, or hopeless? It's a question that's difficult to ask, but very important to be able to know what's going on. Similarly, we should always ask about safety. So some can also have suicidal thoughts. So let's be comfortable asking those questions. Have you had any suicidal thoughts lately? Have you felt like killing yourself? So these questions, again, can be quite uncomfortable, but not asking can actually cost a life. So it's safer to ask. So in many Nigerian British households, sadness is met with be strong, all is well, pray about it. But again, faith and professional support can sit side by side. One doesn't have to replace the other. They're not in competition. They can work hand in hand. So while we're seeking that spiritual care, let's make sure that we are also getting the medical care that is required. So moving on to case study 6 would be urinary incontinence. For this case study, we'll be using Hajia Amina Ahmed, who's 78 and lives with her husband. So with this person, it's been noticed that she has quietly stopped attending her regular gatherings. She's worried about leaking urine before she can reach a toilet, and is too embarrassed to explain why to even her closest friend. So she'll just be turning down engagements and invitations, again, just because she doesn't want to always keep going to the toilet. So again, symptoms that can be noticed in these people will be urgency, frequent leakage, increased nighttime urination, embarrassment, skin irritation, reduced social participation. Again, when they say, oh, they don't want to go out, let's always be sensitive and ask, why is it, and just make sure it's not because of cases like urinary incontinence. So in terms of treatment would depend on what type of incontinence it is. So there's one we call stress incontinence, and that will be sort of like supervised pelvic floor exercise, which should be tried for a couple of months before considering surgery. Another type can be an urgency due to an urgency or overactive bladder. So for this, bladder training would be needed for a minimum of 6 weeks before considering medication. Again, lifestyle modification comes in quite handy with urinary incontinence. So fluid and caffeine review. So sort of like reducing the caffeine content, again, maybe avoiding fluid or drinks 2-3 hours before they go to bed, using the toilet, in the before they go out, and also using pads. Again, that can be quite embarrassing for them to use, but it's quite useful for them, and if it just means they can, go out using that. So weight management is also important, and if there's constipation, that should be treated as well. Again, we shouldn't just say everything is, oh, it's aging, they're growing older. We should look carefully into it, ask the right questions, and make sure they are looked after. So again, it's a treatable condition with real consequences. So there can people can have when they have that continued urinary incontinence, they can sort of like have pressure sores and affecting that screen integrity, and the screen barrier is broken. It can cause a loss of confidence because they don't want to go out and keep going to the toilet every time, or wetting themselves or having accidents, and they can also cause isolation as well. So again, when to refer if they're having hematuria, so that's like blood in the urine, they're having recurrent urine infection, or there's a suspicion of a mass, we should always refer to a specialist to look into. So I'm just going to stop here for a bit while Timmy.
Yes, we'll give you a breather now.
Yeah.
And welcome everybody. That's been an amazing discussion. I'll just hand over to Dr. Supomi Anjorin, who's going to do a brief introduction of the Link family. You're muted.
Oh, yes, I just all right. Thank you so very much, Dr. Tolu. That was an awesome time with you. Thank you very much. I know we still have a part where we're going to be asking you questions. So we would keep that till then. But I want to give us a brief introduction to the Link family. And for some of us who have been part of this series since it started, you will see that we've been doing that. And so please don't be bored by it. That we've heard this already. Why are they telling us again? We know there will be new people just joining. And because we know that there is there is enough to go around for everyone. So that's why we're asking people also to know what is going on here and to be a part of it. So the Link family is an amazing online group which is open to ages from 16 and above that, and is aimed at healing and building healthy and healthier relationships. So we help you in gaining insights in your relationships, your marriages, parenting skills, and life, and encouraging you to healing and wholeness in every aspect of life. And for we believers, we know that, as the Bible tells us in Ecclesiastes chapter 9, verse 4, that to him that is joined to all the living, there is hope. There is so much hopelessness going around, but being part of a living group like this also is a form of hope. And I know some of us have church, some other groups, but this can be one of those in your corner. So it comprises of all age of people and different phases of life. We have singles, we have married, we have older adults, we have very grandmas and grandpas among us, all across the world. People from Africa, from Europe, from United States. I'm talking from the United States right here. So everyone from every tribe, nation, race, religion are welcome. Yet, what the things we're going to be discussing, our worldview is shaped by the belief and the principles in the Bible, but all walks of life, everyone is welcome. And as a person, I can tell you that I've been personally blessed by a series of meetings that we have had on relationships, parenting, blended family, and fertility. And now we're having this particular one, aging and the elderly. And this has been a blessing since it started. And I know that it will continue to be. Most of the, well, all of the meetings that we have had, including our Friday meetings when we do meet to greet, and where we do Bible characters, they are all on YouTube. You can find them on this link I'm going to drop in the chat room in a second. You can find them there just to see some of the things we have had in the past. And even this one that is ongoing right now is being live streamed on YouTube. And you can go back and rewatch some of those things. So we want to let you know that our meeting takes place on Fridays but while we're having this series, it's going to be Saturdays. But on the last Friday of every month, we would have our meet to pray meeting on Friday. So the Link family started in 2020 by Dr. Tolulope Alalade, the present child, and she's the convener. She's a good friend. And again, if you want to be part of our WhatsApp group, which I would encourage you, if you are not, to be part of that, there you can get you can be carried along with all the details and and there are a lot of blessings. Daily we have one thing or another going on for each day that will be blessing to you. And right there in the chat.
Don't joke with this also. Don't come and kill me.
Sorry about that.
Okay. I just muted that person. Nobody's going to kill anybody. Hallelujah. All right. So, so that would be it from the angle of introduction. And please don't forget, note your questions, write them down, and at the appropriate time, we're going to be asking questions. And if you want, would ask you, just show of hand, we'll ask you to unmute and ask your question. And if you want, you can put it in the chat room, and that will suffice. Thank you so very much. I would yield back to Dr. Tolulope Alalade.
Thank you, Dr. Sukome. Over to you, Dr. Tolu.
Thank you very much. So I will be resharing. Okay. Let's see. So let's see. Okay, so we've just finished with urinary incontinence. And the next one will be falls. So just two more, and then we are done. So falls. So we have Pa Emeka Okafor, who's 84, and lives alone in Deptford. He mentions to his home care worker almost as an afterthought that he slipped getting out of bed last week. He didn't want anyone forcing and certainly didn't want to be raised at the community meeting. So common symptoms that could be associated with falls or risk of falls would be unsteady gait, bruising. Could just find that they got bruising all over their body. They would have fear of falling again. So you can tell in terms of when they're walking and they're just being overly cautious. They could also have difficulty standing unaided and would sort of use furniture for support while walking. Again, it's important to note that they may not mention that they've had a fall, and if they do, it will just be sort of like an afterthought, and just believe it's not such a big deal. So we need to be quite careful and pay quite good attention. Again, always asking those questions when it comes to the elderly, because most times they will not readily give the information that something has happened. Again, like I mentioned, always ask every time if you have an elderly person who's over 65 years, how have you been the last week? Have you fallen in the past year or recently? There are sort of scoring tools that can be used in terms of looking at those who are at risk of falls. But most times they are not necessarily recommended. So it might just be okay to just ask directly and then check their gaits and balance. There would sometimes usually be regular sort of like a falls clinic, which is done for the elderly. And they would just go there and sort of look into their gaits and the balance, do a medication review to check that, there are medications that could make them to be at risk of falls, and just generally monitoring them. Again, but when it's needed, we can do a full assessment. So a multifactorial assessment can be done if there's someone who's frail. They can be referred to the frailty clinic. If they've got an injury that needs treatment, or they've had a loss of consciousness, or they've had recurrent falls, they might require a full assessment to check the risk of falls and subsequent treatment. So strength and balance training can be done. Home hazard review, or just be someone going around to make sure that things are in place and the home, the house is not overcrowded, and that things that could easily remove any fall hazard basically in the house. Again, it's important to check that vision, and like I mentioned, to do a medication review. So again, why is this important? So one fall roughly doubles the risk of another. So if there's been a fall, there's a high chance that it would happen again, and it remains a leading cause of injury-related admissions over 65 years. So you find that most times someone has a fall and then they go to the hospital, and then from the hospital they develop some form of chest infection or urine infection, but it usually starts from them having a fall. and having to be admitted. So the last one we're talking about is Parkinson's disease. And we would be using the case of Wale Bankole, who's 71. So his wife noticed first that he's moving more slowly and has a noticeable hand tremor. His children split, between London and Lagos, have noticed whenever they're having a weekend video call or WhatsApp video call that he's having tremors. So common symptoms that might present with these people can be resting tremor, rigidity, their gait, shuffling gait, poor balance, they have a soft voice or reduced expression or difficulty swallowing. Again, with the swallowing, most times they might not even notice it themselves. It might just be someone who's close to them who notices it. That's why with the elderly, it's always very important and useful to have collaborative history from someone who either lives with them or is close to them or is a lasting power of attorney or a carer. In terms of management, it's important to refer quite promptly if a diagnosis of Parkinson's is suspected. Untreated Parkinson's should be reported, to specialists within 6 weeks or even sooner, because especially when they have a high falls risk and they have difficulties in swallowing. Timing is non-negotiable, so levodopa time-critical medication. Again, a high importance is placed on making sure that they do not have a missed dose or a delayed dose in hospital or even when they are home. So there are always great attention is paid to the fact that the timing of medication should always be on time and not missed. Again, antipsychotics in Parkinson's or Lewy body dementia has a high risk of severe sensitivity reactions. Usually a multidisciplinary team would be looking at someone with Parkinson's disease. So not just the doctor or the nurse, physiotherapy in terms of the gait, speech and language therapy, if there's any difficulty with swallowing or with their voices, occupational therapies for independence, social prescribers will go to the house to make sure they're okay. So it's usually a large team of people who are looking after them. Again, let's remember, just give the tablets a little later is never a safe instruction. It's always important to give the medications right on time and not to miss a dose. The timing protects the mobility and the dignity. So in terms of the elderly, it costs the NHS about £18 billion annually to treat these ailments in the elderly. That's why it's important to prevent them or even treat them on time, because with delayed treatment or delayed recognition, it costs a lot, again, in terms of finances to government, and a lot of heartache for the family who's involved as well. So again, just to wrap up with everything we talked about today across all the conditions, let's always ask the direct questions. We had a fall in the last year. How is your mood? Do you feel like killing yourself? Are you feeling low or depressed? Again, they may rarely volunteer it, so that's why it's good for us to be able to be comfortable with asking those questions. Number two, a target is a tool, not a goal. So treatments would most times be individualized for people, especially for people who are frail. The guideline numbers are exactly that. They're just guidelines, but treatments would most times be individualized for the person. It's important to listen to the family member. Again, if they mention things like, oh, the person is using more pillows or actually left the cooker on. Can you imagine they went to the neighbor yesterday and they couldn't come back home because they forgot, how to get back home. They seem to be forgetting things. So it's important to always listen to this from a family member or from someone who lives with them. With most conditions, we normally will try with non-pharmacological treatment first. Again, lifestyle modification in terms of diet and exercise, training, cognitive behavior therapy, making sure an environment is safe for them. So before we give medications, there are always things we can try before going the route of pharmacological treatment. So again, depending on where we live, there's usually a referral pathway for any condition. So sometimes we can just make sure that, oh, okay, GPs are available, make sure we report this thing to them. Some are routine, some are urgent, some are same day. So again, we can always ask a GP in terms of guidelines, which one can stay and which one has to be urgent. In terms of the elderly, let's not get comfortable with putting down things or symptoms. Oh, it's just old age. It is well, let's always be comfortable asking questions. Make sure we notice if there are any symptoms to look out for. So until every reversible and treatable cause has generally been excluded, not waived as aging or stress or spiritual, or it would go away. So with the cases we've shared today, so they aren't just case studies, they're actually, cases that have happened to people around us. These are examples of people's parents, people's, partners, neighbors. So each person that has been raised today in this case study are actually people that we need to look into the symptoms. So the evidence exists, the pathways exist. What they just need is someone who notices and acts on time. Thank you very much.
Thank you. That's been absolutely brilliant. Thank you so much. Without much ado, we are going to go into the question and answer. Are we good to go for that? Yeah. You're muted. You are muted.
Oh, yeah. Sorry. What did you say?
I said, are we good to go into the question and answer?
Yeah, definitely.
Yes. Yeah. Okay. Right. So this is the time some of us have been waiting for. Let's raise our hands. Let's share our comments. Please, let's mute ourselves. Thank you. Kindly mute yourself if you're not speaking, but this is the time to raise your hands. If you can raise it electronically, let us know. If you want to speak, but you cannot raise it electronically and you do not know how, that's the only time you're permitted to unmute yourself and speak. Because I know we might have some older people here who don't know how to use all the icons. I can see Dr. Sukomi Ajorin's hand up. But before I go to him, I would ask a question of my own. And that is the fact that you have mentioned frailty so many times in the course of your discussion. So are you able to just shed a bit more light on that and why it is important?
Okay, thank you very much for that question. So I have mentioned frailty a lot of times because most times frailty is associated with people, as in the elderly age group. So sometimes it's like a specific medical syndrome that is again common in people who have older age, and usually it's characterized by people who have like psychological reserves, who have low energy, who have decreased muscle strength. They are more susceptible and vulnerable to minor stressors. So for example, they might find it harder to fight off things like a chest infection or a urine infection compared to somebody who's not frail. And then they can have like a sudden and sort of like dramatic decline in their condition compared to other people that are not frail. So health professionals would normally recognize frailty using a combination of sort of like markers. So for example, if somebody is losing weight a lot, they want to look into that and say, okay, why is this person losing weight? If they get tired easily, if they are not able to exercise as much, or they have like a low gait speed or poor endurance. So things like that are measures to which you say, okay, consider someone as frail.
Thank you very much. From a GP's perspective, I'm a GP. Sometimes when people come, the first thing will be a short memory test to find out how severe the memory loss is or the memory deficit is. Most of the time, it might take some prodding because a lot of people are not comfortable or happy to be told that it appears like they are more forgetful or they've been repeating themselves. And so their families usually have to persuade them, or more than one person many times has to persuade them before they eventually come in. Sometimes they come in alone and said, so and so said this, they said that, they said this. I just want to be checked out. And sometimes they come in with a family member or a close friend. So usually that first assessment of the memory is done with a short test. And then many times blood tests are also done. So there are some bloods that are called memory bloods. So they include some hormones, some vitamins, that if their levels are low in the body can sometimes affect the memory. And occasionally, if these are found to be low, then corrections are started. Sometimes the memory gets better. In the situation where nothing is low or everything has been replaced and there's still no improvement in the memory, the person definitely has to be referred to a memory clinic where usually scans are going to be done on the brain. They're going to see a neurologist or a specialist in the memory clinic. I'll take Dr. Ijoma Anaso's hand. Over to you, Dr. Ijoma.
Thank you so much, Dr. Tolu and Temitope. Thank you so much. That was very eye-opening. I actually was particularly interested in the aspect when you were talking about depression and you were giving a difference between depression and grief. However, I don't know, I sort of think that when grief is not properly managed, doesn't it have a way of getting into depression? Because a lot of time everybody grieves differently. So sometimes you're just constrained to like, okay, she's still grieving, let me give him or her some time. How can we tell when it has gone from grief to depression? Thank you.
Thank you so much for that, Ijoma. Yeah, so that's actually quite a tricky question. So, for example, when it comes to grief, we don't really have what we call like stages of grief. From the shock to the denial, so like 5 stages that people would normally go through when it comes to grief. Again, there's no time frame for them, so it's not like first stage. Usually, they're sort of like guidelines. Maybe first stage is like 3 to 6 months or whatever. But then, again, that's what it is, a guideline. So you can't be like, oh, normally if one loses a spouse or a partner, by 2 years' time, they should be okay, and everything. It's different for different people. Again, people grieve differently. And then, yes, you have many people who would sort of, like a transition from like grief into depression. Again, if they've not had like the proper support, or, it just hits them quite differently. So again, I wouldn't say there are sort of a hard and fast rule into how to differentiate them. But we sort of have guidelines on how to diagnose depression. So again, if we are suspecting that, oh, this person may have moved into depression, there are sort of ways we can like ask questions to check if it actually is moved from grief to depression. But again, it's important in terms of support people have when they are grieving to ensure they actually have what we call a healthy grieving process, and that it doesn't move on to depression.
Thank you so much. That's very helpful.
Thank you for that. I just want Dr. Shola Oluwanuga, if she can just share her thoughts about that. She's a psychiatrist. And then after her, Dr. Anjorin can speak. Dr. Shola, are you able to speak? Okay, we'll take Dr. Sukomi Ajayi then. Over to you. Let's hear your question.
Yeah, thank you very much. And thank you for the presentation once again. It was really enlightening. I have two questions, or maybe one is a question, the other is an observation, something I observed while you were presenting, which may then be a question in the long run. When you were talking, just giving us the burden of this condition and all the things that you talked about, I saw that you were using statistics from the UK. And there is a tendency for somebody to just look at that and say, oh, yeah, these are Oyibo people's problem. And of course, even though the examples, the hypothetical cases you brought, they are also Nigerians living in diaspora. And they can say, oh, it's because they moved to that place that they had the issues. So is there a way we can relate it to some people who are in other parts of the world, particularly in Africa, Nigeria? That's my first question. The second one is, please, and I know you alluded to that a little bit, I was saying that there is no contradiction between faith and medical care, if that's the way you put it. Is there any particular way in your experience and in your practice that you have seen people probably do well or do better when there is that kind of faith-based support? In your opinion, what can you say to that? Thank you.
Thank you very much for this question. So I'm just going to clarify the first question. So, so did you mean in terms of the statistics for these ailments outside the UK? Was that your question?
Yes. You know, when you were talking, you said in the UK, 1.4 million people in the UK. So that's what I'm saying. Do we have something similar to that, maybe for Nigeria? I mean, I don't want to put you on the spot. It's something that I could Google it so anybody could look at it. But then, just for people to know that we're not saying that these things are peculiar only to people who live in the UK. It is that figure you even gave me just be as even worse if you look at it for other parts of the world, particularly saying Nigeria. That's what I was.
Yeah, so like I said, I don't have the numbers at hand. But again, I guess one thing to consider, supposed to African countries is in terms of how well we keep our data and information. So for example, if you Google, would you even find anything? And if you do find, like in terms of how factual would that be? Because do we go back and always like update that, was it done with some statistics that were done like 1986, and no one has done it, since then. So I guess those will be some of the complexities of the statistics for Nigeria. Again, the second thing you mentioned, whether there's a case of where faith-based care has gone hand in hand with medical care. So again, I don't know with other countries, it's quite a tricky sort of scenario. So someone comes to you and you don't want to sort of mention faith-based sort of things, except they volunteer it themselves. And even then one has to be quite careful. But yes, definitely I have seen people who have come and who are like Christians, and they've sort of mentioned where, again, they've been having like medical treatments for things, but in terms of the outcome, either it's happened in terms of things happening much faster than they anticipated. So in medical, they're having the treatment, whatever it is, and be like, oh, normally this will go in like a couple of months or a couple of years, and they've experienced that happening much faster, or that they've started it and they didn't even have this, they didn't have to, because it resolved so fast that they didn't have to go into other medication. So in a way, basically them saying, they've come for treatment, they are using the treatment, but attested to the fact that because of their faith and their religion, they've experienced the hand of God, in that situation, basically.
Awesome. Thank you for that answer. So some people might not understand when you said we're not able to say much. That is actually United Kingdom thing, in which it is believed that if you talk about your faith to your patients, because of the power dynamic in quotes between a physician and a patient, it can appear as though you are imposing your faith on a patient, which is probably the reasoning behind why you're not supposed to talk to your patients about faith. But some come and they're already talking about prayer, they're talking about how God is helping them. And the thing about faith, whatever faith it is really, is that faith gives people hope, and hope makes people cope better with difficult situations, including illnesses. And so that is important and should be encouraged for them to be part of a support system. It's a support system for them as well. Okay, over to you, Nancy. It's good to see you. Let's hear your question. You can unmute.
Thank you. Good evening, everyone. My question is, were those research, are they only done on like the minority, like the African culture or the Caribbean culture? Do we have like a broader ethnicity, like the Caucasian, things like that? Do we have any database on how they are affected or how they respond to those illnesses or incidents, for example, falling or diabetes and, different things that we've spoken about? Because the reason why I'm asking, because I live in Denmark and my ministry is to kind of broad people, not just a specific race, not just for African or Jamaicans or whatsoever. So do we have a database, proven database on different ethnicity, how different illnesses affect different people?
Thank you very much, Nancy. I think your question is quite similar to the ones to come in asked. So in terms of database for like ethnicities and different countries, yes, I do believe they exist. Again, it depends on, how much the country does in terms of updating those statistics and how much is done into acquiring those statistics. Yes, but I believe for different ethnicities and different countries, there are statistics out there for different conditions. Does that answer your question?
I think she wanted to know from your presentation, because I think she must have assumed that your presentation was kind of skewed towards African and Caribbean minorities.
Yeah.
But I think what Nancy needs to know is that your data was actually based on the data from the United Kingdom that you got, isn't it?
Yes,
You
it is.
just
Yeah.
specifically picked out some things which you felt would be a bit more relevant to us. That's why you spoke about them. But her data is related to the United Kingdom as a whole, which consists of different nationalities.
Yeah. And I suppose coming to the link, I knew that most of the audience will be Afro-Caribbean as well. So I thought I would sort of make it to that demographic.
Is that helpful?
Yeah.
Okay. All right. Thank you.
Thank you.
Yes. Any more questions from the house? Yes. So I have a question, and that is, first, let me greet all the men in the house. You're amazing. You are seen. You are loved. You are needed. We appreciate you. Happy Father's Day in advance. Okay. So it appears like it's quite difficult for men to voice out their concerns about their physical illnesses or ailments. They kind of find it a bit difficult to talk about when they are feeling unwell, when they are feeling down. I had a client that came and had something going on for 4 years, and he said he was there because of his wife, because his wife dragged him into the clinic. And you just wonder, why is it so difficult? Why do you do this? You deserve to live well. You deserve good health. You can't be taking care of everybody. I'm taking care of my wife, I'm taking care of my children, and you don't take care of yourself. Because if you don't take care of yourself, there won't be any more of yourself to take care of anyone after a while, because you won't be there. So I don't know whether you can speak to that and give us your thoughts on why it is so. Is it a cultural thing? What can be done about it?
Thank you for that. I would say that that was probably more the case because there's a lot of pressure on the men and the fathers to be the provider, the protector, and be there for everyone and be everything. And so it's difficult when everybody is looking up onto you for you to actually say, oh, this is actually happening to me. And also in terms of, I also may have a lot of ego. So again, you won't regularly go and meet a GP and be like, I'm having urinary frequency or urgency, you sort of feel like the man, you won't go and say that kind of thing. But again, I would like to think that that is changing a lot. Because I think now more than ever before, I'm seeing a lot of men related sort of like meetings and groups. So men's health, I think there's more of that publicity and recognition now. Is like, men, it's okay for men to cry, it's okay for men to have problems. Men's mental health, there's so many meetings now there, and I think there's increased awareness as well. And I suppose culturally as well, to come out and just say, look, it's okay to be not okay, and speak out, and there's help there for you. Like you mentioned, thank God to our, wives and partners. They've been doing a good job of, like, you need to look after yourself. So that, I think, would be my opinion on that.
Okay, thank you. And I know sometimes their wives tell them and they don't listen. They just shrug it off and say, I'm okay, I'll just take some paracetamol, I'll sleep it off, and all of that, until it becomes like a serious thing. And especially, I definitely want to mention this. If you live alone, whether you are a man or a woman, please be very careful with your health, as in take it seriously. Especially, there's nobody to prod you. There's nobody to say, oh, it's looking like your eyes are looking somehow today, or you're looking a bit this. You have to look after yourself. You have to take that responsibility. Look in the mirror. If you are feeling somehow, take a day off. Work will go on without you. The world will exist without you. So if you need a break, please take a break. It's not a badge of honor not to take a holiday, not to take a break, not to sleep enough hours in the nights. There are some things money can buy. So if money can buy help, use money to buy help and get some good rest. I advise everybody, I say, if you're over 35, 40, you don't need a television. You need a blood pressure monitor. You should have a blood pressure monitor in your house to take it from time to time. Of course, I know some people go overboard with this, because some people tell me, I take it in the morning, I take it in the night. In my mind, I say, what are you looking for? If you're not unwell, you don't have to take your blood pressure that frequently. But if you're known to have high blood pressure, or it runs in your family, at least once a month, check your blood pressure. If you're unwell, check it at that time as well. If you're feeling dizzy, check it at that time. So there definitely has to be a balance, not too much, not too little, but please take care of your health. If you're opportune to have a spouse or a partner in your life, do the needful. Touch all the places you need to touch. Look at their scalp, look at their back, look down below. You have opportunity to do that. Use that opportunity. And if you don't have that opportunity, please do it yourself. Check your breasts. Look at things that do not appear normal and tell somebody about it, especially a health professional. Thank you. Sounding like I'm ranting. Yeah, I think you have some hands up now. Dr. Sukwami, let's hear you.
Yes, thank you. When you started by saying, so man, Happy Father's Day, I know you were going, you have something under your sleeve for us. Well, in all honesty, because of the do I call it the facade, the way man will show and all the abracadabras and all those things, there is a tendency for everybody to think we are fine, and which is why most of the time things get dropped fall through the cracks, and men, that's why you see even in the statistics, men we have lower compared with our same female age group, lower life expectancy and all of that. So, and Dr. Alalade mentioned one of the major things there, which is the natural man ego to just come down and say, I am this. And that's why this campaign has to be very loud, where it is okay to not be okay. And as a man, you are not the provider. You are not the one who has to. God is the provider, is the source. You have to be where you need to be. Yes, you should be responsible, but not carry the whole heaven and earth on your head while you are dying. And I need to say this also, just in my own little work with especially married couples, I found that when you see a man who is readily coming out, who would readily volunteer things that they are struggling with, there are men who happen to, and this is grace, who happen to have found a safe space. And this is where not just the wives, but we can start with the wives. The way I see it, most men who would readily come out and readily tell their wives things they are struggling with are those who have found the woman to be a safe space, not going to be judged, not going to be looked down upon. They can be vulnerable. So when men find more of that, because our ego can be so protected, overprotected sometimes, that when you know you are going to tell somebody, I can't feel so thing, I'm not able to do something, they are going to look and say, what's you that you think you are the almighty daddy is the problem. And I think our mommies can please help a little more in that area. I think I'll keep quiet soon.
Thank you for sharing. That's a much needed discussion. It needs to be louder. Dr. Christiana, your hand is up. Let's hear you. Thank you.
Yes, thank you so much for the presentation. Going back to the figures that were quoted, the statistics, if there's an ethnic minority in UK or in America and they imbibe the lifestyle of the country they are residing in, will the figures reflect the country they are living in or their original primary country?
So, yeah, thank you for that. So for example, in the beginning, when it was like over 1.4 million people in the UK, so it would reflect everybody living in the UK, except it specifically says Afro-Caribbean community or, whatever ethnicity. But if it says generally in the UK, it will be everybody living in the UK.
Thank you very much for that. Anybody have any other questions? Any comments? The meeting is supposed to be between 5 and 6:30 for the presentation and questions. And we've had one amazing speaker today, so she's all ours. Give her the questions while she's here, or any of your comments if you have any. Thank you. So we are going to have other sessions about delirium and dementia, specifically because they're important. We are also going to have a session about mental health in the aging and the elderly, as specific sessions as well. So we'll be able to dilate a bit more regarding that. And while we wait for whoever has a question, I was just going to say that Dr. Sukomi has talked about the part that wives, spouses play in the health of their spouses. The Link family has done a series when we talked about the relationship series about relationships and health. So there's a lot you can do to help your spouse in their health. But we also need to talk about parents, because it's the parents that imbibe what ends up happening in their children, especially when they are still young and malleable. So if your child needs to speak, you need to give them opportunity to speak, whether they are male or female, especially if they are male. We need stronger males. We need more vulnerable males. We need responsible males. We need teachable males. The world has changed. We are constantly evolving. So sometimes specific things do not fit anymore. Everybody has to be able to adjust when push comes to shove. Everybody needs to know basic life skills. You need to know how to cook. You need to know how to do some basic things. You need to know how to change a tire. You need to know how to take your own blood pressure. So, and so the issue about parents, especially mothers or fathers, telling their children that especially their male children, that it's not okay to cry. You're a man. Don't you know you're a boy? Why are you crying? It's okay. It's okay for men to cry. It's okay for boys to cry. Jesus wept. He is the Son of God. So if the Son of God could cry and it was recorded for our benefit, it's okay for men to cry. So please allow whoever wants to cry and express emotions. It is also known that when women cry and express that emotion, it helps them to get over things. It is useful. We are giving our tear ducts for a reason. So it's okay. So there are some things we need to normalize, some discussions we need to normalize. Of course, it's beyond the scope of this, but there are also many other things that are taboo in our culture regarding health that we don't really talk about, that we should talk about. So please let us take the effort to be able to do that so that it does not become a stronghold down the line and people are finding it difficult to talk about when they are going through difficult situations. So with no questions, let us take our final words from our speaker. What are your final words to the house today?
Hello, everyone. Thank you for listening and thank you for all the contribution. So I'm sure we all have elderly people around us, be it our parents, be it neighbors, family, friends. If there's anything to take home, it would just be the fact that, again, they will not readily come out and volunteer information about what they're going through, because they're just that sort of, they don't want to lose their self-confidence to come and tell you, I'm having problem, passing urine, or, I can't see properly, or things like that, because they're just sort of that, pride and being able to do things and not needing help. So let's be intentional about asking questions and asking directly, because it's only when we do that we can be able to see if there's anything that needs sorting out and being able to help. Again, let's always check on our elderly ones. I know we are all busy, but this is the time they need us. So let us check on them, call them, and make sure that they are okay. Thank you.
Thank you very much. Thank you very much, Dr. Alalade. Okay, thank you. You've been such an amazing audience. Thank you very much. They were a bit too quiet for my liking. Big thank you to those that joined on YouTube. Big thank you to everybody in the house. Thank you for your comments. Thank you for your questions. Thank you for being part of the meeting. It's been great. We have, so this is number 3. So we have 9 more sessions coming. The next session is going to be on bone and muscle health in the aging and the elderly, and it's going to be taken by an orthopedic and spine surgeon. So it promises to be quite an exciting and interesting discussion. Big shout outs to our brothers, our sons, all the wonderful men, our fathers in our lives, spiritual and temporal. We hail you. We are very, very appreciative of all you do. And to those who have gone beyond, may they rest well and may their memory continue to bring us joy. Okay, so before we say our motto, are we able to take a group photo? Dr. IJ? Yes, ma. Dr. IJ, are you ready? Are you there?
Yes, I'm here.
Okay.
We may need to turn on our videos so that we can take a screenshot.
If you don't mind, are you able to turn on your videos so that we just take a group photo? Our sister, Dr. IJ, is coordinating that, and then we'll take our motto together. If you're able to turn on your video, that'll be amazing.
All right, thank you. One more, please. Just one more.
Turn on video, please, not audio.
Okay, thank you. I think I've taken.
You have taken a couple. That's amazing. Thank you so much. Let's say our motto together. You can unmute yourself as you say our motto together if your background is not noisy. I live in love.
I live in love.
I stay in peace.
I stay in peace.
I shine my lights.
I shine my light.
I use my power.
I use my power.
So help me God.
So help me God.
Thank you so much. Thank you so much.
Thank you.
Thank you.
Thank you.
God bless.
Thank
Bye-bye.
you.
Bye.
Bye-bye.
Bye-bye.
Bye.
Thank you, Dr. Tolu. My regards to our dear neurosurgeon. I think I saw him before. Dr. Kayode, good to see you. Prof. Omisojo, good to see you. Dr. IJ, thank you. Sister Nike, thank you.
Thank you.
Mr. Fumi Van, thank you. Dr. Oluwanuga, Mommy and Prof. Ayedo, thank you.
Thank you.
Thank you. Sister Adiola, Mommy Oguntubi, good to see you, ma. Thank you, ma. Mr. Oshokwale, good to see you. Mrs. Oketade Bolale, good to see you. Mrs. Olufumilayo, I know. Thank you for joining us. I can see
God bless
iPhones.
you for the good work you're doing. God bless
Thank
you.
Amen. Thank you, ma. Mommy Olabisi Jaji, thank you. Good to see you. Apostle Andrew, good to see you. Techno Spark, thank you for joining us. AKD Spark, Sax, thank you. My regards to Alaga, our Alaga. Brother Tunji, good to see you. Brother Olorutoba, good to see you. Thank you, everybody. God bless you. See you next week by God's grace.
Amen. Amen.